Great to be here. Thank you. I even recognize some of those things that I participated in here over the years. I facetiously say occasionally that my career actually peaked when I was chief resident in 1971, and I've been on a long, slow glide ever since, but that's probably not true. If I do this, I'm really delighted to have this opportunity to talk with you. And in the instructions that Emma sent me for this, I'm going to present a case to you in a minute. But ACEs, adverse childhood experiences, PACEs, positive childhood experiences, have a pretty important role in adult health. And I was worried, as I'll show you with the case I'm going to present, that you, our colleagues who do primarily adult medicine, may or may not be aware of all of this. So I'm really happy to have the opportunity to talk. But since we're in the Schroeffel conference room, I ought to point out Bruce Schroeffel, who's right here. Does that work? Yes, it does work. There he is. Bruce, who was president of University of Colorado Hospital when we moved out here, and across the table from him is Lily Marks, Doug Jones, who was chair of pediatrics here in the early years, and then my senior associate dean for clinical affairs, and Jane Shoemaker. Lily and Jane were our finance deans at the medical school and were directors of what was then UPI, now is CU Medicine. Anyway, the four of us happened to have lunch last week. We have quarterly Nathan's hot dog lunches where we import Nathan's hot dogs and sit and talk about what the place used to be. And occasionally, if a problem comes up, Doug sings out and says, NOP, NOP, which means not our problem anymore. And this group is either retired, as these four are, or as I am, not quite retired. I'm down to 60% time at the Kemp Center, but I can tell you being just a professor at this school is really terrific because not a single person works for me and I don't have a single performance review to do after years of many of them. So here are my disclosures. Sadly, I have no financial conflicts of interest. My four sons have continually pushed me to get onto for-profit boards, but I have nothing but not-for-profit boards on my resume. I did, when I stepped down as dean, start the National Foundation to End Child Abuse and Neglect. You can look at that on a website. My dream was that it would be like the March of Dimes, because the field of abuse and neglect has no 501c3 raising money to stimulate research, training, or prevention, as the hundreds, if not thousands, of existing ones that are attached to every organ of the body or every adult and pediatric disease have done for the last 40 to 50 years. And that's a little bit the reason why NIH's budget has gone from 100 million when I was an intern to the 47, maybe now a little less, billion it is now. That's been driven by the efforts of groups like the March of Dimes and the American Societies for pick an organ, lung, liver, heart. They're all there and they've all been very successful. So I thought we could start one. I can tell you we were not successful. It's at a pause at the moment. It's basically been funded by some people and my retirement, but I've come to the conclusion that it actually isn't so easy to start a national foundation from the Mountain Time Zone. Nobody knows where the hell we are or what time it is here. And we don't have enough billionaires per capita as New York, LA, Chicago does. So we're currently seeing who we can connect with in other time zones. I also want to acknowledge Christina Bethel, who's professor of public health at Hopkins. She and I are collaborating on a number of projects, and a number of the slides I'll show today are hers. And then I did a recent survey that some of you may have responded to, and I have the research team at the Kemp Center to thank for those slides. So here are the objectives, and we will go through those as time goes, but we need a case. Some of you may remember Joel Levine. Joel was my senior associate dean for clinical affairs from 1992 or 3 till about 2006. And we were sitting in a meeting in my office one morning at 8 o'clock, and he was looking at his schedule for the day. Wasn't on a phone. Remember, we used to have calendars. And he was worried. I said, "What's the matter?" He said, "Well, I'm seeing this patient. I haven't been able to figure out what's going on with her. She's had chronic abdominal pain. I've seen her for the last year. I have done every test I could. They're all negative." And so I said, "Have you ever asked her if she had experienced abuse in childhood?" And he said, "No, why?" And I said, "Well, actually, our literature in the child abuse field suggests that there is, in fact, a link." And he said, "Well, how would I ask that?" And he said, "Well, I said, "You're in a perfect position to ask. You could say, you know, your pain isn't caused by anything we've looked for this past year, but I recently learned that there is a relationship, and it could be related to physical or sexual abuse in childhood. Has that happened to you?" He said, "I can do that." And for that afternoon, I got a call from him, and he said she burst into tears, and she said, "No one has ever asked me that before." And yes, she had been sexually abused in her childhood. And he said, "Now what do I do?" Well, at that time, interestingly, our Department of Psychiatry was not so interested in this particular area. But I knew a number of people in town who were very good at treating individuals adults who had experienced abuse, who are now called those with, used to be called survivors, now called those with lived experience. That was followed up by other conversations I had with members of this department. We've had 2 past presidents here of the Obesity Society. And a number of years ago, I asked both of them individually, what percentage of your obesity patients in the clinic have experienced abuse in childhood? And they would say, when I said, "Do you ever ask about that?" they would say, "No, why would we?" And so the recurring theme was, it seemed to me about 10 years ago, and maybe it has all changed now, that this was perhaps an area of either agnosia or amnesia in the training of individuals who are caring for adults. I had another one with another faculty member, and it was during the pandemic, and I actually watched the program, which was all about social determinants of health. And this has been an interesting conundrum because child abuse and neglect is never discussed as a social determinant of health. Although frankly, my view is that those who do experience significant child abuse and neglect, in fact, those are the health determinants that put them in a place where the social determinants come into play. They wind up with substance use problems, they wind up being unemployable, they have personality disorders and a wide variety of other things. So I think that health determinants can be indicative of poor social outcomes. So let me just do a little historical context. This is not a new field. Around here where we have the Kemp Center, we always attribute the efforts and abuse and neglect to Henry Kemp and his colleagues. But there are Egyptian hieroglyphics that depict abuse. And interestingly, there was a Greek obstetrician by the name of Soranus, who in 200 AD wrote the first textbook of obstetrics and gynecology. And the last chapter of that textbook was called The Newborn, because that's sort of what obstetricians have to do after they've done the whole thing. And in that chapter, Soranus said, you need to be careful when you choose a wet nurse for your baby. He said, wet nurses need to have an even temperament, because if they don't, when the babies cry, they will, quote, shake and tremble, and the babies will fall from their hands, and they will later come in with big heads, and he called it water on the brain. But we're pretty sure that what he was really talking about was what were subdural hematomas leading to big heads in those infants. And that was really the first medical allusion to what we now call abusive head trauma and was called shaken baby syndrome. Ambroise Tardieu was a French pathologist. He was the medical examiner in Paris. He described 32 children who had died of abuse in the 1860s. He also described the sexually transmitted infections in young Parisian girls in the late 1860s that he said had to be caused by sexual abuse. And he called on French physicians to do something about the problem of physical and sexual abuse of children, and he was ignored. It was Henry Kemp here at our institution who described the battered child syndrome in 1961. Could I get the water, Emma, please? Thanks. He presented, thank you very much. Henry actually submitted his abstracts on the battered child to the Society for Pediatric Research in 1959 and 60, and he was turned down both times because it was felt not to be appropriate pediatric research, and he couldn't rule out other causes other than trauma for what he was describing. And so, not to be dissuaded, Henry got himself appointed to the Council of Scientific Affairs of the American Academy of Pediatrics, and the job of that person was to organize the annual meeting of the Academy. And in November of 1961, he had a 3-hour symposium that was entitled The Battered Child Syndrome. There were 1,000 pediatricians in the room who sat through a 3-hour presentation where Henry described the pediatric aspects, Fred Silverman, the radiologic aspects. Brant Steele was a psychiatrist who described his interviews with the parents who had abused the child. Bill Drogmuller was actually a medical student here at the time, a 4th-year student. He did the first study to try to find out the incidence of battered children. He sent pictures of Henry's patients to pediatric services all over the country and asked, have you ever seen children like this? And the number came back 302. Henry thought that number was a little low, so they sent the pictures out to district attorneys all over the United States, and their number came back 447. So if there had been no overlap on the basis of what he thought was 749 battered children in 1961, an entire country after this presentation changed its laws, recognized abuse, and required mandatory reporting. The interesting thing about his presentation was after 3 hours, the 1,000 pediatricians walked out. There was no applause. Occasionally there were boos, and almost all of them said, "Not in my practice." And it probably would have died there, except Henry put in the front row a reporter for the Chicago Tribune who picked up the story. And the next day there was a headline that said, "Battered Children in America," and the field took off. As a result of that, he testified in 37 different states to suggest that physicians had to be required to report their suspicions. And at that time, it was child welfare to whom it was reported. And in the 1960s and 70s in the United States, the child welfare system was actually helpful. This slide describes his interest in the problem. He was furious with what he saw as denial, with people coming in diagnosed osteogenesis imperfecta tarda, being diagnosed in children with broken bones at 3 years of age, failure to thrive of unknown etiology in a child who gained 2 ounces a day in the hospital. And he said what really he felt strongly about was that this was denial from intern to resident to attending to specialist of an obviously trauma or neglect situation that wasn't good for our intellectual honesty, nor did it do any good for the abused child, his siblings, his suffering parents, most of whom he said we could help. Now, I'm going to flash forward through 6 decades as we get into ACEs here. The pediatrician's denial was there, but what really changed everything in this country with regard to how we were dealing with abuse, and as I mentioned, in the 60s, late 60s, and most of the 70s, child welfare departments were actually helping families. And most of the follow-up studies that Henry did here showed that 90% of the physically abused children who were being abused in their families could be treated and safely be with their families and not be re-abused in the future. But in the mid-70s and late 70s, we rediscovered the problem of sexual abuse in this country. And unlike physical abuse, which has a huge tolerance for not calling the police and not being a criminal offense, we have a 0 tolerance for sexual abuse without, in fact, calling the police. And that is what blew up the entire child protection system in the United States and has left it, in my view, for the last 40 years, ineffectual. In this 1990 US Advisory Board, 15 of us said that the state of child protection in this country is an emergency. And I can tell you that 35 years later, it's the same. There hasn't been much progress at all. The mortality of abuse, which isn't counted accurately, but at least 1,800 to 2,200 children have died of abuse every year for the last 40 years. We've made no progress in reducing the mortality of physical abuse of children, even though we actually know how. The CDC and NIH funding in this area is incredibly small. For years, it was the director of the National Institute of Child Health and Human Development said it's a social problem. They deal with it over in the Office of Child Abuse and Neglect, which has been buried on the human services side for years. Well, that brings us to 1998, when Vincent Felitti and Robert Anda, Vince, an internist with the Kaiser Permanente system in San Diego, and Anda, who was a senior scientist at the CDC, published their study, which was entitled The Adverse Childhood Experiences Study. And what it confirms is that adversity in early life increases physical, mental, and behavioral problems later in life. These were the 10 adverse childhood experiences. 3 of them are abuse, physical, sexual, and emotional abuse. 2 of them are neglect, physical and emotional neglect. The others were mental illness, incarcerated relative in prison, a mother who was treated violently, meaning domestic violence in the home, substance abuse in the family, or a divorce. Their study showed that if you have 4 or more of these adverse childhood experiences, the likelihood of you dying early and having a lot of physical and emotional problems are severe. The prevalence of ACEs in our country, psychological abuse, the prevalence is thought to be at least 11%. I think that's an understatement. Physical abuse by parents, 28%. Sexual abuse by anyone, 22%. And sexual abuse of boys and girls, men and women, the prevalence is different. About 2/3 of the sexual abuse of women is intrafamilial or in the extended family. About 80% or more of the sexual abuse of boys is outside the family in scouts, teams, schools, churches, a variety of other areas. And the reluctance to talk about this is significant. The average age at disclosure of sexual abuse by women is in her 50s. The average age of disclosure of sexual abuse in childhood by men is never. Neglect, emotional neglect, 15%, physical neglect, 10%. And then alcoholism, loss of biologic parent, depression, et cetera, are shown there on the slide. This is a very tough slide to go through, but basically see if I can do this. I forgot how I was going. There it is, the mouse. Having childhood psychosocial adversity actually has impacts on genetics. There are epigenetic changes, leads to developmental trajectory that can lead to increased risk of cognitive deficits, disease, psychopathology, and social problems. There are sensitive periods in childhood where this will imply. The reference here can go into this more in depth. It's just a lot more complicated than any of us thought 15 or 20 years ago. And the spectrum of maltreatment is, of course, a spectrum. Physical abuse, psychological, sexual abuse can happen in an isolated way. I think all of us can remember, and my wife and I reported this back in the 80s, of an outbreak of emotional abuse in a classroom. I think all of us can probably remember of the 100 teachers we had in elementary school and junior high, at least one who was abusive. If you've had only one abusive experience, whether it's physical, sexual, or otherwise, that's not likely to cause a lot of downstream problems in contrast to those who have ongoing physical or sexual or psychological abuse in the home. The effects of toxic stress on the body are illustrated here. It clearly has an impact on the hypothalamic, pituitary, adrenal axis. And there have been impacts in the neurologic system where ongoing abuse affects the fight or flight response, the activation of the amygdala. I'm not going to go through this whole list, but it also impacts the immunologic system. And we see a lot of adult patients with endocrine changes as well as the epigenetic changes that cause significant, although many maybe subclinical issues for your adult patients who've experienced a lot of abuse in childhood. Toxic stress can emerge through strong, prolonged, uncontrollable chronic stressors. It can start early in infancy, and it can go on through childhood. The toxic stress can activate the stress response, which can get stuck, leading to changes in brain architecture, hormonal or immune responses, which again lead on. So what can we do about this? 17 years after their paper came out, Filippi and Anda came up with this list as to what they could do. I put an asterisk up on the first one, and we can discuss whether this is feasible or not when we have time for some questions. But their view is we should routinely seek a history of adverse childhood experiences from all parents by way of a questionnaire. They've actually done this in California. Nadine Burke-Harris is a pediatrician who got appointed as the Surgeon General of California. She got Medi-Cal to reimburse all clinics and physician practices if they would do an ACEs screen, and attached $49 to the reimbursement so that at least there wasn't a negative reimbursement to do it. And they did that for 3 years while she was Surgeon General. They're in the process of evaluating that, but I can tell you there's a lot of discussion in the field, and I'll talk more at the end about if we are going to do something like a routine screen in this regard, how we should probably do it. They say if it's positive, you need to acknowledge the reality and ask, how has this affected you later in life? You can try to use existing systems to help with current problems, assuming your existing systems are functional. We need to develop systems for primary prevention of these experiences in childhood. We actually know how to do a lot of that. We just haven't been able to get it up to a scale where it matters as much. And it can be reimbursed through Medi-Cal, even though, as I said, not everybody agrees with it. So that led me, and how do people taking care of adults relate to this? This was a study that showed inter-clinician variability in primary providers' ACEs knowledge. And if you look on this particular screen, somewhat familiar is maybe 25%, 12 or most, but the majority are vaguely or not at all familiar. And that's what actually led me to decide this year. I was told at the beginning of the year I had a post-tenure review and I better start doing something other than sitting around as just a professor. So I actually decided to do 2 surveys this year. And some of you may have received the survey that I did, where I asked several hundred medical staff in different departments on this campus, do you ask about abuse in childhood? To my surprise and actually pleasure, psychiatry came up most positive here. I say that because for about 40 years that I tried to work with our Department of Psychiatry here, before Neil Epperson came, we had a contractual arrangement, not a collegial arrangement. They were not at all interested in the field. And I actually think if Brant Steele, who was the psychiatrist who worked with Henry Kemp, hadn't had tenure before he started working with Henry Kemp, he probably wouldn't have gotten it. So this was a real positive change. But for those doing medicine, primary care, geriatrics, The bulk of these, and this is literally a week old in the analysis, and we got to do a lot more analysis with it, but there are a fair number of sometimes, and there are a lot of no's. And when we looked by department and within the degrees, because we have MDs and PAs and others, this is that scatter. Most of these are the MDs. And when we asked, why don't you ask about it, the two biggest reasons actually were either I never thought about it or I don't have the time. And then we asked, why don't you include abuse history in case planning? And I didn't receive training is the first one. Asking these questions isn't part of standard practice is the next. I don't have time is significant. And the patient's past trauma wouldn't impact the treatment plan. I have no way of knowing whether that's true or not, but I just thought I'd share that since at least some of you filled it out for me, and we'll do better. So with all of the work on adverse experiences, what Christy Bethel and her colleagues have been looking at most recently is how do people get through that? 30 years ago, Brian Steele told me, or 35 years ago, maybe 40 when I got in the field, there was this perception that if you were abused as a child, you would become an abuser, that there was this so-called cycle of abuse. That is not correct. It is correct that every abusive individual we have ever seen, whether it's physically abusive, sexually, or emotionally abusive, have themselves been abused, but the vast majority of abused children and adolescents will not repeat that cycle. And the reason they will not is they get the message from someone that what's going on isn't their fault, it's not their problem, and they have other adults who they can look up to and model themselves after. And what Christy and her team have done is they have realized and measured in this child and adolescent measurement inventory that if you look for positive experiences, and I'll describe them in a minute, positive experiences will in fact become a counterbalance to the adversity. And among the 7 positive experiences in childhood are being able to talk with your family about feelings, feeling a sense of belonging in high school, supported by friends, have at least 2 non-parent adults who took a genuine interest in you, feeling safe and protected by an adult in your home, feeling your family stood by you during difficult times, and being involved in community activities. And this particular reference goes through how Christy and her team have now, in I think 5 different states, embedded measuring, looking for, and stimulating positive childhood experiences in their statewide systems. The Kaiser Permanente group here in Colorado uses this, uses her work as well as a lot of other places. And so what really happens is if you only have adverse experiences, the ACEs will begin to weigh you down, and yet positive experiences over time will cumulatively develop the coping skills that you can shift this fulcrum's position, making it easier to achieve positive outcomes. And so screening for adverse life experiences could explain why the fulcrum is shifted to the right, because lots of people are doing that now. And it increases the probability for negative outcomes, but that's only half the equation. Positive experiences and coping skills can shift the fulcrum to the left, increasing the probability of positive outcomes. Preventing the negative is not the same as promoting the positive, and the absence of positive is negative. And so many people who don't have ACEs and who lack positive experiences can also have negative outcomes. And so that's where we are with the adverse and positive experiences. Toxic stress and how to address this in the clinical situation was a topic back in a number of years ago in the pediatric literature. This is a quote saying, physician factors which can lead to difficult clinical encounters. I probably don't have to tell this group that we've all had difficult clinical encounters, but whether it's burnout, insecurity, and tolerance of diagnostic uncertainty, et cetera, I'll leave this here and you can look at the slides later. When they did a national behavioral health primary care integration learning collaborative on trauma-informed care back in 2017, patients who've experienced trauma just want to know that they'll be respected and that people will explain things, that you'll have choices that won't be trapped, and all of this is important to achieving good outcomes. And it depends not only on what you do for the patients, but how you do it. And there are efforts and people who can help with that process. So let me sum up, just as I've thrown all this out at you, just some final thoughts. I don't know whether incorporating this into internal medicine practice is easy or not. It certainly won't happen if what we decide to do is ask the medical assistants to ask the questions as they're checking us in. I've had the experience, as maybe you had, but for 3 years that I brought my spouse here for care, we would sit down and the medical assistant would look at me and then look at my wife. And then she would say, Mrs. Krugman, do you feel safe at home? And there'd be no answer because my wife had expressive aphasia. And after 30 seconds, she'd look at me and I'd say, I believe she's safe at home. And she'd check the box and move on. Getting the boxes checked is not what's helpful here. So we've got to figure out how to do this. It is perfectly true that you shouldn't be asking these questions unless you have supportive professionals available. And as I mentioned earlier, happily, our Department of Psychiatry seems more in tune, and there are plenty of people in the community who can help as well. And I've always thought that this campus is a good place for us to break through some of the discipline-related and intergenerational compartments that most of us live in. That can only lead to better outcomes for our patients and those who rely on us for care. Finally, I hope this overview will get those of you in adult medicine interested in testing whether anything I've presented has any relevance in your practice. We could use a lot more people doing research in this area. The absence of what I'd call appropriate levels of support from NIH over the last half century, during which time we've been trying to address abuse and neglect, has left us decades behind in our ability to care for the adult population, and we could sure use your help. I'm done. Thank you.
Dick, thank you. That was thought-provoking and also eye-opening in so many ways. I'll start us off with some questions. I think the first question I had was, I was surprised to see the amount of resistance from within your field when this was first discussed. I mean, historically, there's been a long sort of record of this. Why do you think there was so much resistance at the time?
Henry's resistance came from pediatricians who did not want to It's uncomfortable. I don't, you know, I don't know how many times those of us who work in this field, and it's similar to people who worked on oncology, people say, you do abuse? How could you possibly do that? That's horrible. Because people's vision is that you're dealing with horrible people. The reality is we're not. And all of us have an area that tweaks our interest. For me, I was always interested in human behavior. Not enough to want to be like the psychiatrists at NYU where I went to medical school, but interested in human behavior. And the first case of abuse I ever dealt with, I was interested not only in the behavior of the mother who would kill her baby, but the 25 health professionals who could have prevented the death but never did because it never occurred to them that a parent would do that. So I think it's uncomfortable, but that's the discomfort I felt, frankly, in oncology. When I was in training, every child with cancer died. And I wondered, how could anybody do that work? Well, happily, people got involved, and it was because, I am sure, they had individuals in their family who had cancer and they wanted to do something about it. And just, I have her permission to talk about it, I found out late in my field that in fact, we had abuse in our family. My sister, it turned out, had been sexually abused by my grandfather for 3 years, from age 9 to 12. After I left, I was her babysitter, but I left for prep school and college. And I didn't figure that out till 2 years into my work at the Kemp Center when she was being hospitalized for a suicide attempt. And my father said, come talk to her. And I talked to her and I said, you're acting like someone who's been abused. And she said, I thought you knew. So the taboo to talk about it is what has really complicated things. And you know, we're getting better at that with suicide. We talk about suicide now. When I was growing up, I had an aunt who died of breast cancer. In the 1950s, we never talked about cancer or breasts. So I didn't find out till 1970 what she died of. So that's, I don't know what.
Yeah, that's very helpful.
Okay.
Thank you.
Yeah.
Questions from the audience? Dr. Bull?
It's good to see old friends again. Good to see long time friends again.
Now getting to the old friends too, but great talk and really fascinating area, Dick. So I'm curious because especially when you get into the scoring systems, sort of dealing with more like the emotional side. I mean, so I think that, you know, the traumatic abuse, the truth, that's probably easier to deal with. But I'm wondering how you handle like cultural differences, things along those lines as you put this forward into some of these other areas. You know, like divorce, that's like half of America right there. And then you like sort of saying emotional abuse, that again, there may be some cultural aspects of that that some would consider abuse, other would be like, that's just, you know, how fathers are, something to that effect, you know. So how do you handle that in this analysis and that sort of thing? So
thanks. First of all, you're exactly right. You know, when you look at the ACEs score, 50% of American children will have at least one, because there are at least 50% of marriages that have divorce as part of them, so they've lost a parent. It's only at the upper levels that it gets significant. There are clearly cultural differences in this, and there's a whole literature on that. One of the more common examples is corporal punishment, where children are spanked or hit with objects. In the little study I'm doing, asking people who've worked a long time in the field, what progress have we made? Corporal punishment is actually one of them. 50 years ago, 77% of children were hit with something. With my sister and I, it was a hairbrush. And we knew my mother was angry when I came with a handle, not the front of the hairbrush. That's down to 29%. So there are clearly cultural issues. One has to be sensitive to it. And if you take the approach with families that is not to call child welfare or the police, but if you take the approach of saying, you know, there are other ways to do this. The whole child protection field started, Henry's phrase was, abusive parents love their children very much, but not very well. And our job is to help them do it better. So if you see something like corporal punishment happening that may be more prevalent in a certain cultural group, you have a conversation and you give other alternatives. That's not the time to call. I'm trying to get our field to focus a lot more on the mortality side. The fact that our mortality is unchanged in 40 years is pretty unique in pediatrics and medicine. Did I answer all of that? It's all right? Okay.
Can I follow up, Dick? So is this, what do we know about this in other countries? How well is this measured? Is this a very American, North American phenomenon, or?
It's all over. Different countries are at different levels, and it won't surprise anybody that we have in the child abuse field some people who are really gung-ho about bringing the message to every country in the world. And in fact, Henry Kemp started the International Society for the Prevention of Child Abuse and Neglect. And we'll be meeting in Vilnius, Lithuania in October. But there are parts of the world where this has got to be like number 5 down on the problem list if you've got a country where you're still ravaged with infectious diseases or sanitation. There are different approaches. It appears to me, and I was trying to study this in Europe, the Dutch and the Belgians came to Denver in the 1970s to learn how to do a child protection team and deal with this. They took it back, and in 1990, when my colleagues and I said, we have an emergency here, they called me and said, we're better. We put ours in the health system, not in child welfare. And I said, great, do you have any data? And they said, data? So I said, I need to take a sabbatical and I need to come over. And that's where I was going in 1990 before I wound up in the cul-de-sac of the dean's office for 25 years. And by the time I got to Belgium and the Netherlands in 2016, they had blown up their whole system because child protection systems are driven by scandal, not by data. And a child dies and they throw up their hands and they change the director of the agency. Or a child dies and they decide, well, instead of saving children by putting them in foster care, we'll preserve the families. But the same number of children are dying, whatever they do, because they don't look at outcomes. European systems, I think what I hear from our colleagues there is they don't see the severity of abusive head trauma that we do. I think it's because they have a much stronger social safety net within the Eurozone of helpful child welfare services. All of the social workers who were in our child protection system in the 60s and 70s went into private practice when the whole system basically became an investigation agency, and they just left. So we don't have the supportive system. And the other thing that happened, and this was a problem that I lay at the feet of our beloved former First Lady, Rosalind Carter. Right at the time we went from thinking there were thousands of children and families who needed mental health services to the millions we started identifying in the 80s. She, as the spouse of the president, deinstitutionalized all the chronically mentally ill and completely filled our community mental health system with severely needy patients. And we couldn't get mental health treatment for any of the families we were trying to help. That's why instead of being dean, I had always hoped to be the spouse of the president, but Mary wouldn't run.
Other question, a question in the back.
Thank you for a great talk. I was just interested in, given the shortcomings of our child welfare system in this country, do you feel that there is any need to amend the mandatory reporting guidelines or training, not just for providers, but also for teachers and anyone else who is a mandatory reporter?
Yeah, terrific question. The response, the knee-jerk response to disasters like child abuse deaths, and 50% of child abuse fatalities happen in children who have open cases with child welfare. The knee-jerk response is to pass another law or make someone else a mandatory reporter. We've just had a mandatory reporting task force here in Colorado. I sent them a long note that was ignored because we've never evaluated it. And the truth is, until child welfare and the courts go through the transformation we did in healthcare in the late 1990s, where we suddenly said, after 35 years of quality and outcomes research being done within the health services research community, where Michigan and Yale and UCLA and the Robert Wood Johnson, for 35 years, people were looking at de-identified data at all of our institutions, presenting it in their journals, talking about it at their meetings, and never bringing it back to us who are making the mistakes. Until, say, Don Berwick and crossing the quality chasm, now you can't get accredited unless you can show outcomes. That is unknown in child welfare and in juvenile court and in law enforcement. So until that happens, we're not going to get anywhere, I don't think. My modest proposal is that we would give 10 communities the opportunity to have what I would call a do-over. Give Denver County or maybe Pitt County, or give a state like South Dakota or North Dakota, or give a Native American tribe. Give 10 places the opportunity to come together for a year, bring all of the key agencies and people together, and say, if we had the chance to create a child protection system that would assure that all of the children born in our community beginning 2 years from now could grow up in an abuse-free environment, what would that look like? And then give them the resources to test it and measure the outcomes over 10 years compared to the people who aren't doing it. And that'll be the first time those people's outcomes have been measured. And maybe a decade from now, we could actually develop a system that protects children.
Dr. Krugman, thank you. We're one more question perhaps, and then we will be at time.
One of the senior senators. I remember him from the faculty senate.
Dick, I was going to ask about kind of maybe a different form of child abuse. Right now, it's clearly in the news. Many parents choose not to vaccinate their children against potentially fatal diseases and things. And I see that sometimes referred to as child abuse and whatnot. I personally would tend to put it in that category. How do you view that sort of thing? I mean, it's obviously something that's extremely important right now with the measles outbreak. And
Yeah, Well, that's a politically fraught question.
Perfect for a former dean.
I, you know, ultimately that will be decided by courts. Do I personally think, I think it's neglectful not to vaccinate your children. But there are religious reasons that why for a long time. I think we're caught up in a public frenzy at the moment where polarization is more important than conversation. I've always, maybe I've overestimated myself. I've always believed that given enough time and enough conversation with parents that I could help them get to what I thought was a good outcome. But if they didn't, I wasn't going to take them to court over it, nor was I going to report them over it. And
Thanks, Dr. Krugman.
the
A
time of the
politically
gentleman
artful
has
answer.
expired.
What's that?
The time
The
of the
time has
gentleman
expired. Thank you for a very thought-provoking and
Thank you.
interesting talk. We look forward to more conversations. Thanks, Dick.
Nice to be here.